Welcome to the second of the Pearls from the OR course. This one will be focusing on deformity surgery. We have 2 days, two short days of talks with some really great speakers. The thought of this meeting was to make it more the way I've described it to the speakers that we've invited. We wanted this to be more of a how-to than a why do we do it this way. So we're not going to get into a lot of discussions of why to do this over that, though there should be some of that. But the main thing here was a more practical, more asking some of the experts in the field how they do things. So welcome everybody. Spread the word if you like this meeting to all of your friends and colleagues. Suggest that they join the World Spinal Column Society, send them to the website. Because the more people who are involved, the more learning opportunities like this we can do. And hopefully in the very near future, we will be able to be doing these in person. I'd like to have our president, Salman Sharif, say a few introductory words, and then we will get started. Salman?
Yeah, a few introductory words. Welcome, everybody. Doug, off you go. All yours.
Okay. All right. Our moderators for the first session, where did they go? Are Professor Obad Saud from Ain Shams University in Cairo, and a former president of the society, and also another former president of the society, Yanis Politourakis from Athens. They're going to be our moderators for the first day. Take it away, gentlemen.
Thank you so much. Yanis, are you here?
Yes, I'm here.
Okay, thank you, Dr. Orr, and thank you, Dr. Mehmet Zalili. Myself, Dr. Orr, and Dr. Zalili are the co-directors of this course. Thank you, Doug and Mehmet, for giving me this great chance. Thank you, Salman, for all the activities this World Spinal Column Society is always introducing. We are the Society of Hands-on Education. We like this definition so much. I will leave now the floor for Dr. Yanis Politourakis, the immediate past chairman of this World Spinal Column Society, to begin this session. Dr. Yanis.
We will start with our first speaker, is Dr. Thomas Kuivila. He's an orthopedic spine surgeon. He's a pediatric orthopedic surgeon. He's the vice chair for education of the Orthopedic and Rheumatology Institute and the residency program director in orthopedic surgery in Cleveland Clinic. Dr. Kuivila, is your.
Thank you. Everyone can see my screen?
Yep, we got you.
Great. It's my pleasure to talk today about growing rods for juvenile scoliosis. Now in the pediatric realm, we are referring to this more as early onset scoliosis. Why they needed to change the name is not entirely clear. But this essentially is for the juvenile group is from age 3 to age 10. Some of those are idiopathic. Many of them are neuromuscular, as you'll see from some of the cases I showed today. So they wanted us to start with a case. So I'm going to start with one here and make sure I can advance my slides. Why is it not advancing? There it goes. All right. So this is a young girl who has neurofibromatosis type 1. And you can see looking at her, she has a right thoracic curve. It's not your typical dystrophic curve that you might see with neurofibromatosis, but as you can see, her triradiate cartilages are open, and she is clearly someone who has a significant curve and needs some attention. In the realm of early onset scoliosis, we worry a little bit less about magnitude and a little bit more about flexibility. Taking care of a 60-degree flexible curve is not a problem later on. So 60 degrees tends to be when we start looking at these. So this is a girl that was indicated to do something about this curve, and what we used were some of the magic magnetically powered rods that you can see here. We'll talk a little bit more about the specifics of those. The motor unit here in the middle of the curve, the magnet is in here, as is the motor. You can see that they're in opposite directions, so that as you're putting the magnetic device on the back, you're not activating both at the same time. One of the limitations of this is this central portion cannot be contoured, and hence you look at this and you might be aghast at how flat her back is. But you can contour the top and you can contour the bottom. And if it's a very small patient, this occupies a significant portion of the overall construct. So the amount of contouring you get is a little bit limited. But if you look here, and then we go to the next slide, you can see how over the course of 3 or 4 lengthenings, these are typically done every 3 months, we've maintained, if not improved a little bit, her curve. And here you can see this little gap here is an indication of the amount of distraction that we've gotten. The attachments in here are as you would attach any spinal instrumentation with pedicle screws. Of course, the challenge in someone who's 7 or 8 is that the pedicles can be fairly small, and sometimes up at the top, they can be to the point where there may not be anything of substance at all. So you can see that we've used a hook construct up at the top. This is a down-going transverse process hook. This is an upward going laminar hook. And even though we're distracting this, this helps to lock it in. So a few words about growing rods. Obviously, this involves instrumentation without fusion. The idea is to preserve growth, attain some initial correction, and control ongoing deformity, knowing that eventually this person is going to go on to an instrumented posterior spinal fusion. This is not a new idea. You always have to reflect back on somebody like Harrington. Back in 1962, he proposed that very young children could be treated without fusion, and as is often the case in the annals of orthopedic surgery, this was used for polio patients. Here you can see this was just a simple Harrington rod construct with the ratchets here at the top. As time progressed, people were using a single rod on the concavity and just doing intermittent distraction. That's why the rod has some excess here at the top. The problem with the single rod is twofold. I mean, you can still use it nowadays, but sometimes you will require some bracing. But there have been a couple of good studies that have shown that just a single rod has a fairly high failure rate, and the most common failure rate is hook displacement or rod breakage. And you say, well, I'm not going to use a hook, I'm going to use a screw. But like I said, sometimes in the upper portion of the thoracic spine, getting a screw of substance is a difficult deal. So people went to dual growing rods. I'll have some examples of that. These were a little bit more stable since there are 2 rods. People were using multiple fixation points above and below, you put some bone graft in these regions, and it helps to solidify, especially if it's a hook construct. And this is an example of how we used to do the dual growing rods. You can see the connectors here in the middle. You've got good fixation here, good fixation here, nothing across the apex of the curve, though some people once upon a time would put a little bit of bone graft on the convexity in a way of providing some kind of tether. That really didn't seem to work quite as well as people were hoping that it would. So when you're putting in rods like this, these can be either done subcutaneously, whereby you expose the top and bottom of the construct and then slide them in subcutaneously, or in a thinner patient, or when we're looking at the magnetic lengthening rods, you want to put them submuscular, yet at the same time, it's important not to expose subperiosteally, as these, if you wink at subperiosteally exposed bone in a kid, it will go on to fuse. So the non-union rates, in the child adolescent population are not anything what they are in the adult world. The other way of doing this construct is a couple of companies make a long sleeve in which you insert the rods where they're essentially touching, and then every 6 months or so you make a little incision, you put a distractor in there, and you push the rods away from one another and try to get a centimeter and a half of distraction. The problem, of course, with the growing rods is having to keep going in, and even the dual rods, such as you just saw, have some issues. Right here in Cleveland, George Thompson, about 15 years ago, hard to believe it was that long ago, found that the dual rods without apical fusion were the best in terms of overall curve correction, overall growth of the spine during the growth rod phase. And he found that in his series, apical fusion, excuse me, was not effective. So that leads us to, another type of construct, which is the magic rod, a portmanteau, I guess, of magnetic expansion and control. And this is a cartoon. You can see the two motorized rods with the fixation points above and below. So the reason you see a standard rod and an offset rod, you'd say, well, why can't we just flip this one? It'll look just like that one. And there's nothing internally that's different about these two different rods, other than the fact that the manufacturer makes one end long and one end short. And so that's why they're separate kind of rods. So that way these can be at roughly the same level. And that's a useful thing to have them at the same level, because usually there's a sweet point in the back where the patient will be able to have enough room for these two motorized units. The motorized units measure about a centimeter in diameter, so they're not huge, but they're certainly bigger than the usual 5.0, 5.5 millimeter rod. The anchors for this are going to be similar to traditional growing rods, but the nice thing about these is that whereby in a standard growing rod construct, you have to take the child back to the operating room every 6 months, put them to sleep, make a little incision, expand the rods. You can do this in the office without additional trips to the operating room. And so not only are you saving the cost of the operating room, the issues with general anesthesia with a young child, but you're also able to do this more frequently, which is a benefit, and you're minimizing your risk of infection because you're not re-exposing hardware a couple times a year. The lengthenings are done with this little device that we put on the patient. This particular photo is a little inaccurate because they don't have their shirt on when we put the device on. But this device has here in, let me get wrong screen here. There you go. Here and here, some really powerful magnets that when you actuate it by putting your button on here, they spin around, and the magnetic inductive force goes to the rod, causes it to spin inside and then distract. So here is that patient that you saw a little bit earlier. When the family found out that they weren't going to have to keep going to the operating room, they opted to have that changed into a growth rod construct, and the child has done well. Still getting lengthened a couple millimeters every 3 months, and is set for a definitive spinal fusion probably at about 9 months. But you can see this fairly tight thoracic curve, and we're not going to expect to bring that around, but the overall spinal balance is quite nice. This is a kid who has Marfan syndrome and had a fairly significant right thoracic curve. As you can see, his shoulders are leaning way out over his pelvis. And this was one of the earlier ones we did. And you can see that from the middle slide here, pretty decent correction of the curve at the very beginning before we've done much distraction. I was a little bit concerned about the overall stability. And so early on, we were putting most of these in braces. As you can see to the, if you look on the side, you can see the bracing straps. Since that time, I've felt more comfortable. These are not just the old Harrington rod with a hook above and hook below that has a chance of dislodging. Dislodging is not a problem with the more modern growth rod constructs, and with four fixation points above and below, I feel pretty confident not putting these kids into a brace. This is what he looked like when the distraction was complete. You can see from the gap here, that's how much we were able to distract over the course of about 3 years. You can see these little plates right here. Those are not orthopedic doing. That's from a heart surgery he had. So those are some kind of sternal plates. So even though he, or rather, despite having the hardware in, he was still able to have a cardiac procedure for his Marfans. And then we move on here to his final construct. And there's not a whole lot of difference between here and here. By the time you have lengthened these, they're fairly stiff. They start to almost auto-fuse, even in the absence of having exposed those posterior elements. I think just locking them up probably causes some early arthrodesis to occur. That being said, it's a whole lot easier to do your final definitive fusion following distraction, in that the curve is of much lower magnitude. One other thing I want to add here at the end is how you can use a growing rod construct in lieu of traction. Previously, we essentially used traction of some sort for all early onset scoliosis that was in excess of 80 degrees, especially scoliosis associated with kyphosis, because distracting over the posterior aspect of the spine when you have kyphosis obviously is only going to make that kyphosis worse. So the concept of traction was to loosen up the scoliosis and the kyphosis before you did some kind of vector or subcutaneous rod placement. I'm not really discussing vectors because I'm not. But anyway, Stagnera developed the halo gravity traction concept, and this is how we used to put kids in traction. They'd have a halo ring during the day. They could walk around with a little walker. They could sit in a wheelchair, and then by reclining their bed, there would just be some body weight traction in the evening. Kids don't like that, and parents don't really like that either. So if you can do something about their curve, maybe somehow address their kyphosis in a way that's not this extra skeletal traction, people can be happy. So this is this is not an early onset curve. This is just a curve that sat out there in the hills of Appalachia for many years before finally coming in. She measured 110 degrees. And the options were manyfold. One was to consider traction, doing some preoperative, or now I guess it is operative, doing some releases, both front and or back, and then putting her into traction for a few months, and then going in and doing her fusion. Well, fortunately, she didn't have a significant kyphotic deformity. So the thought here was to use some internal traction. And so what we did is we put in a couple of growth rods, one that was trying to bring over the drift of the thoracolumbar spine, and then one just going up across the main part of the thoracic spine. And so this is what she looked like when we started the screen to your left, and you can see the magnitude of the curve. And then through some distraction, you can see we distracted here and then distracted here a little bit less. I didn't want to push that way over, but I did want to open that up a little bit. And so we were getting some significant improvement overall with the internal traction device. And then we went on to do her final fusion. And you can see these things over here are the sublaminar cables, sublaminar web straps that several companies make. Her pedicles on the concavity of her thoracic spine were microscopic in terms of they had become so dysplastic. I was actually worried pulling on the lamina might just kind of pop them off, but unfortunately they did not. But here on this screen, if you can see, these are these web straps that go sublaminarly and then attach to this little device here that allows you to tension them. They're obviously more expensive than sublaminar cables or sublaminar wires, but they, by virtue of the fact that they're about 5 millimeters in width, they really distribute the load nicely and are do a nice job of pulling the spine over to your rod. You can also tension these sequentially without fear of breaking the web, and so that works well. And so this is her final construct. It's a little goofy looking. Obviously, she still has a significant amount of rib rotational deformity, but she's actually she's actually very happy just based on the overall improvement in her trunk appearance and now having level shoulders. But this is an indication right here. You can see these hooks again. There really wasn't much in terms of a pedicle, but these hooks look like they're going sideways, and that's an indication just how much rotation she still had in that area. Very, very stiff spine, but I think in the big picture, it helped her a lot. The particular growth rods, the thing about the new ones with the motor, they've had some issues with metallosis. And of course, as you can see with the two other pictures on this slide that I pulled off the internet, the United States lawyers are just salivating to make some money over the fact that patients have had some issues with the magnetic rods. But that being said, they still do have they still have a role. They're still making them. They're working on the metallosis issue, and I think overall it's a great way to cut down on infection rate and trips to the operating room. The only problem is, of course, their cost. So it's one of our happy patients who decided to have the symbol for titanium tattooed next to her scar to commemorate the fact that she had some titanium in her, and she was a happy camper. So with that, I will turn it back over to our moderator. Thanks.
Thank you so much, Dr. Kuvela, for this very nice presentation. And I think, Doug, we will keep any questions till the end of.
Yeah, we're going to do questions after Chris's talk.
We have now Dr. Ahmed Alani. Are you here?
Yeah, I'm here.
It's very good to see you. Professor Alani is a professor of spine surgery in Hacettepe University in Turkey, although he was graduated from University of Ankara. He had a fellowship in Kansas City Medical Center and a visiting professor in UCLA Medical School before, and he is a world-renowned expert in treatment of spinal problems, especially scoliosis and spinal deformities. We are looking forward to your talk, sir. Go ahead.
Can you hear me?
Yep.
Okay. So thank you very much for the nice introduction, and thanks to WSCS for inviting me to give this talk. And hello, everyone. Greetings from Istanbul. And today I will try to give you some pearls from our OR, especially on this new motion preservation solution for idiopathic scoliosis. Here are my disclosures. So this is my case, 13-year-old female, almost 14, with a lanky type 1AN curve, as you can see here, around 40 degrees main thoracic curve, which was unresponsive to brace treatment. Then we had to give a decision as the curve reached to 40 degrees, just at the threshold of the surgical treatment. And she still had some growth potential as she was Sanders 3, according to the left wrist and hand X-ray, and she was pre-menarche. So this is the X-ray of this patient spine lying. This is actually a new method that I use even more often than the bending X-rays. But I also have the bending X-rays, and as you can see, the main thoracic curve is quite flexible with a 50% of flexibility, and also the lumbar curve is very flexible. So in this case, of course, according to this template, which is suitable for the growing patients, and as our patient is a Sanders 3 patients who was unresponsive to bracing, and the curve has reached to 40 degrees. So we considered surgical treatment, and for the surgical treatment, actually, what we have is fusion, or we also, after this experience, our experience has started with VBT surgery, we can also select one of the non-fusion or hybrid solutions. So disadvantages of fusion, especially for this patient, potentially maybe limitation in motion, interfering with growth in this patient who had a significant growth potential yet as she is pre-menarche Sanders 3. And we are also concerning about the adjacent segment degeneration disc disease with the fusion surgeries, as you may have known. And also, this is very rare, but this may also happen. Lack of bone healing may cause rod breakage pain and loss of correction in the fusion surgeries. And one of our final concern is weakening of the back muscles. But at the end of the day, I always hated to do fusion surgery for a teenager, as I thought that it's not a physiological treatment method, and it's creating another pathology to treat one pathology of spinal column. But anyway, of course, for selected cases, it is still the most viable option for majority of the cases, sorry. So we still use it. And in my practice, actually, more than 40% of, still more than 60% of patients are fusion patients. Okay, so. Okay, so non-fusion scoliosis surgery VBT is actually relying on the Hütter-Volkmann law. So what we do is we are modulating the growth, and then we just tether the convex side of the curve by using the cords, as you can see here. And by doing this, actually, the compression on the convex side decelerates the growth at this side, and the traction, which is provided by the compression of the convex side, the traction on the concave side is accelerating the growth on the concave side. So we actually use the benefit of the growth potential, and by growth, the patient has spontaneous more correction over the correction that we provided by the index surgery. Just an example, this patient, for example, who had a 54 degrees of lumbar spine, lumbar curve, and 44 degrees of thoracic curve, has been operated by a double curve VBT surgery. And as you can see, we were able to get correction to 14 degrees, 17 degrees in the index surgery, and in the thoracic spine, and 24 degrees in the lumbar spine. And by time, as you can see, at the end of the 2-year follow-up, we were able to get a very nice correction, which was 3 degrees and 10 degrees overall. And you can see also the satisfactory correction in the patient without any posterior skin incision. So what are the advantages of this kind of surgery? Motion preservation, we spare the growth. Actually, we use the growth potential as an advantage, scar hidden under bra, shorter hospitalization, and rapid recovery. What are the disadvantages? We don't have the long-term results yet, although I've been doing this surgery since 8 years. So my longest follow-up is around 8 years, and we don't have the long-term results, and especially we should be waiting for the long-term studies. But I don't know when, how long the results will give us a satisfactory conclusion about the efficacy of this surgery, because as this is a mobile spine and as there is always a tetrabreakage rate, I think we have to follow those patients maybe until the end of their lifespan. So I don't know if this will be answered, easily. So it may necessitate multiple surgeries, especially due to the overcorrection, tetrabreakage issues, which are the main problems with this surgery. And there might be a necessity to convert this surgery to fusion surgery if the surgery fails. And there is also a less harm correction in patients with no or less growth potential. I think it's important to know all these things. Of course, we have discussed with the patient and the family about all these, potential disadvantages and complications. But at the end of the day, we decided to do the VBT surgery. So how we do it? It can either be done by an open surgery, as we were used to doing in our anterior fusion surgery experience. But it can also be done by a thoracoscopic approach by using 5 to 6 keyholes, as you can see here. So this is our preferred approach, and we have done up to now over 150 cases, and we didn't have to convert any of them to open surgery. And you can see the steps here. And I just would like to give you some pearls about the technique. So patient positioning is the most important thing, and we have to be really working on this. Am I online?
We can see it.
Yeah, can you see? Can you follow?
Yep, we can, Ahmed.
Okay, the patient is positioned in the lateral decubitus position, as can be seen here. And this positioning is very important. Actually, I try to get as much rotational correction and kyphotic correction as possible by positioning the patient. And then we have to just determine the landmarks for our portals. And we just look at the posterior line and anterior line. And then we just get some AP views to determine our working portals, as can be seen here. And then our next step is just to start with our first portal for the visualization of the thoracic cage. And we just try to open our mid portal size. And then after opening this, we enter into the chest cavity and just see and count our whether we are in a good place by counting the ribs. And then after exploration, all these things with a 30-degree scope, we try to place the upper portal, and we use an injector, as you can see here, and saline, and just trying to hit the upper vertebra that we will be instrumenting. And by using this trick, we determine our upper portal to visualize. And as you can see, after the upper portal, then we work on the lower portal. And so the distal portal is opened, and this will also be later used as the chest tube insertion point. So exposure starts from the upper portal with harmonic scissors up to T8. And this is how we do it. So we first determine the T5. And as you can see, we are working on the parietal pleura. And then after determining this, we just try to dissect the parietal pleura. Is a longitudinal line, as can be seen here. And I'm just fast forwarding here. And then I do not hesitate to ligate or burn the segmental vessels, segmentary vessels, especially if it's a right-sided curve, as you can see here. And after opening the chest, pleura, and ligating the vessels, as can be seen here, and especially if it's a left-sided curve, then we usually try to preserve the segmental vessels due to our concerns of Adamkiewicz artery. And from time to time, we can have left-sided curves with some syringomyelia, especially. This is also important to preserve these segmental vessels. And as you can see, by preserving them, also we can easily insert the staples for our screw heads, for our screws, screw insertion. So then, after the completion of the exposure, we also dissect or expose the diaphragm, the crus of diaphragm by the thoracoscopic method, and we are able to reach up to L1 via a thoracoscopic approach. And then we prepare our portals for instrumentation with 2 centimeters of incision. And we first start with the uppermost one, and the portal is placed according to our path to T5. And again, we determine the trajectory of T5 by into the chest, and then we start instrumenting or screw insertion. And as you can see here, the screws are placed from cephalad to caudate, and we try to be as anterior as possible to provide kyphosis in AIS patients who are usually hypokyphotic. And afterwards, our next step is just to go and start from our lower side, the caudal side, and this is an L1 screw insertion for this patient. And then after hammering our staple inside the vertebral body, what we do is actually we just use a tap, as you can see here, and tap the whole thing. And then we just measure the length of the screw. This is very important, and this is very tricky, because the screws should be bicortical purchase, but they should not be long. We were not hesitating to leave long screws in anterior fusion surgeries, but here, as the vertebral bodies are moving, they may, by chronic irritation, they may actually cause aortic aneurysms, so they may injure the vessels. So we should be very careful on this. And so this is our second screw. So my plan for this patient was to do a double row of tether, especially at the apical side, because of my concerns of tether breakage in the future. So the idea is, if one tether breaks, then the second tether actually holds the curve and does not allow the correction loss. Okay, so you can see the same steps here. Okay, and as you can see, I'm inserting here staples for my double screws at the apical side. And here I usually prefer to insert first my posterior screw, and I'm just opening the hole here. And tapping it. And measuring the length. And inserting the screw. And now the anterior one with the angulation and then inserting the screw. It is very important that the screws from the side view, as can be seen here, to be on the same line, because any zigzagging may really put a lot of stress on the cord, and it may be the reason of the tether breakages. So from time to time, I just check if my screw trajectories are online, looking at the side portal. Okay, so the same steps here. And then these are now T6 and T5 screws. And as it is very difficult to insert two screws, usually in those growing patients for T6 and T5, I prefer to use a single screw and single cord here. And actually, there is not too much breakages through this side. So I'm not concerning about tether breakages, especially at the cranial side, T5 and T6. And I use these gauze to stop bleeding when I'm changing the instruments. And the average bleeding in our case series was around 75 cc. So this is not actually a bloody operation. Okay. So then, again, this is T5, the last screw. And after completing the T5 screw, the next step is insertion of the cord. Sorry, you couldn't, yeah, this, I just skipped that slide. Okay. Then the correction maneuvers is by usually manual forces, especially translation and the rotation, as you can see here. And after correcting and parallelizing the end plates to each other under fluoro, and doing the rotational correction and translational correction, then I use this distraction device just to apply some compression, actually to initiate the Hütter-Volkmann law and to get some more correction. But I usually rely on translational movements and rotational movements because, you know, applying too much compression on the cord may cause cord breakages. Okay, now it's ready. So my next step is to insert the cord. So as you can see, the cord is pushed through a hole, and then I'm getting it. And the first thing I do is securing the cord on T5. As you can see here, I'm fixing it by fixing the set screw. Okay, now my cord is secured at the most cranial vertebra. And then the next step is to do the same thing in the T6 screw. I don't apply any compression to T6 because, you know, it gives a lot of load on T5, and sometimes it may cause the pullout of T5. So I go step by step. You see here my compression device. I go to the next one. And for every level, if this is if it's a curve, mild curve as this one or moderate curve as this one, 40 degrees, then I just use my screw holder here, as you can see. So by doing this, what I do is I try to make the two end plates parallel to each other. And also you can see on the screen how the vertebra moves by using this screw holder as a joystick. Then I bring my compressor. After holding the two end plates parallel to each other, I just apply some compression on the screw. So my idea is always to make the end plates parallel to each other. I try to avoid too much compression at the cranial side and the caudal side, but I try to do as much compression as possible at the apex. As you can see here, also this shows how I am rotating one vertebra, the vertebra which will be compressed over the next vertebra. And again, I think these translational movements and rotational movements are really are to be used more than the compression forces to upload the cord into too much stress and cause a breakage of it. Okay, so after fixing the whole thing, I go to the most caudal vertebra. This is the last one, as you can see. I just push the diaphragm, and then here usually I don't apply any force, and I just secure it, the cord into the screw. As these sides are the most common size for the overcorrection, and mostly the cranial and caudal sides. Again, I don't apply too much compression forces at these lower and upper ends. Then I just cut the cord by using my harmonic scalpel. Yeah, and this is the end of the first row. And then I do the same steps in the second row, in the posterior row. So if the patient is having a lot of growth potential, also, if it breaks, then usually there is an overcorrection in some patients. Overcorrection may also cause some breakage. So I just compress the vertebra here on the posterior line, less than the ones that I compress anteriorly. This is also not to ruin the kyphosis that I can create, by compressing the anterior line screws. Okay, so it goes like this, one by one. Sorry, my slides are a little bit long, but I try to make it short. And this is the final one. And again, I secure the cord. And this is right after the surgery. I do a final hemostasis and check, all the bleeding vessels and coagulate them. And then place my chest tube after the control and finish the surgery. So one of the tricky things is how much correction we should aim in the first index surgery. So I usually aim to leave, it depends on the Sanders maturation status of the patient. Usually for Sanders 3 patients, I try to have around 20 degrees of curve in the first erect patients. That means considering the slacking of the rod when the patient is erect. So I try to leave during the surgery, in the surgery on the table around 15 degrees. So here, as you can see, is 12 degrees. And if that patient would be a more immature patient, then I would try to leave more residual curve. If that patient would be a Sanders 4 or 5, I would try to do as much correction as possible, as I am not concerning about the overcorrection. As you can see, the patient in the first erect X-ray has been corrected to 21 degrees, and this was what I was aiming, and I was able to get this at the end of this surgery. So thank you very much for listening to me.
Thank you so much, sir. That was a very, very nice presentation. Yanis?
Yes, now we will have the talk from, I'm very glad to present him. He's a friend. He's also, we are working together in many cases. He was awarded the European Spinal Deformity Fellowship in 1998, and he had his spinal fellowship in Manchester 2001. He has worked in many UK hospitals and also Greek hospitals. And also, he was an elite athlete and an Olympian in Rome. Vasilis, I'm waiting for your talk. We are all waiting for your talk.
Thank you very much for the invitation, and thanks, Yanis, for the introduction. I will present you now with my...
Vasilis?
Yes, can you hear me?
Yanis forgot something very important.
Oh.
Vasilis is the rowing champion, Olympic champion in the Olympic Games in Seoul Games in 1988.
Oh. I'm not an Olympic champion, but I am an Olympian. I took part on the coxless 4. But anyway, can you see my screen?
Not yet.
Not yet. So how do I share?
There's a button at the bottom that says share screen.
Yes, I have pressed that.
Try again.
Okay.
There it is.
It's
All
working.
right.
Yes.
Yep.
Okay.
Yep.
So we will talk about the correcting high-grade spondylolisthesis with laparoscopic correction. We first started with more simple cases, and we were trying, the whole thing is about 540 degrees correction with posterior release, then anterior laparoscopic introduction of cages, A-lift cages, anterior lumbar interbody fusion cages, and then posterior stabilization with MIS for fusion for one disc space. You see here grade 4 spondylolisthesis, and you see that in the beginning we were not scratching exactly the surface, but we have taken the anterior part of the sacrum, but the cage is big enough to make a good fusion. And then we have started to succeed a better correction of the deformity and of the listhesis by making it from grade 3 to grade 1. Of course, we have succeeded with this minimal invasive procedure, all the characteristics that we aim for. We do not need specialized instrumentation for this correction, and we use much longer operative times. The whole procedure, posterior, anterior, and then again posterior, takes a lot of time. The posterior release, it's usually taking a couple of hours with the insertion of the screws, the dissection, and the full removal of the facet between L5 and S1. And then we turn the patient around and we do the laparoscopy, which takes usually 3 hours. And then we turn the patient again and we do the final correction and the rods, the insertion of the rods. Of course, you need to master the open technique. In Manchester, it was the main center in England for anterior procedures, thoracotomies, and open laparotomies for correction. And we can see the anatomy. The main problem is the bifurcation in the vena cava to the common iliac left and right. We need to take good care that the patient will not be older than 55, because otherwise the vessels will be very brittle, and we will have hemorrhage which will be uncontrolled, even if we try to put sutures on that. You see that we have to make a clear space of the L5S1 anterior prominence, and we have to ligate the two small vessels that come out from the common iliac veins, and we must not use ligation, but we need to try to be as careful as possible. You see here the positioning of the patient, and usually the insertion has to be in the same line between the anterior pubic bones and the L5S1. Everything will have to be parallel to the upper surface of the sacrum. We need to be very careful about that, because if we cannot have a straight line between the anterior pubic bones and the upper surface of the sacrum, we cannot succeed in this operation. So positioning of the patient, or putting a pillow or two under the pelvis in the patient, is very critical. In the early 90s, in the United States, they have tried to insert small cages, but there was a 20% failure for fusion, because as you can see, there was not enough space for the bone to fuse between these. By late 2010, there were some papers with excellent results, 100% fusion. They all mention that there is a big danger if you don't close the peritoneum, in the case that you will use BMP2 for the improvement of the fusion. But we do not do that, because we use the big A-leaf cage. Of course, you know all these possible complications, and one of the problems is the retrograde ejaculation. In our cases, there are only 15. We never had this problem. And if you take in consideration that you should not do patients that are older than 55-year-old, you will not have many problems with the veins. We had 12 patients, 9 women and 3 men, many kind of different problems, degenerative spondylolisthesis, revision cases. They all had posterior, anterior, and then posterior instrumentation. We do not use BMP. This is a patient from the Libyan war. As you can see, all the posterior at L4-5 is destroyed by a bullet. He was mobile, but there were a lot of adhesions, so he could not use the posterior way. This was actually our first case. You see a lot of portals in the patient's abdomen, because we were starting with him and we're not wanted to have always the best visualization, but also use different kind of tools. This is the big Medtronic A-leaf cage, which is actually 25 millimeters wide. And you can see that there is a huge area for fusion. And you see with the posterior, a very nice correction and stabilization in this disc space only. We will see now a video, if you allow me. Excuse me. It has excellent visualization of the abdomen inside. Then you change the main entry of the portal and you start inserting your instruments. You identify the disk space and you mark it. And you insert the size. You have cleared the disk from the area to see the end plates, and you put the right size of the cage. You see how you hook the cage. You insert the bone from the two facets that you have removed. So you have autologous bone. And we do not proceed with these screws because we are doing posterior instrumentation. Now we will see the main video from the procedure. These are here some adhesions in the patient's abdomen, which we ligate in order to free the interior. Then we put these hooks to the periphery of the abdomen, and in order to hold the intestines, and we hook them in the inner part of the abdominal wall, as you can see, as you will see here. You see, we take them and we hook them up on the internal side of the abdominal wall in order to clear the area. Here we have put Kirchner in order to hold the common iliac vein from the bifurcation. And so we will never have, you see the Kirchner here and here, we have the disc cleared the disc space. So these are permanent. You need to pay attention when you will detach them in the finish of the operation. And here we will make the first cut of the disc. It's all being done with hammer. I want to have exact pressure on the instrumentation. So I hold them very tight in order not to slip. And then I push them with the hammer in order to have a specific power. And you see the Kirchner. And then we start to clear the disc. The good thing is that the Kirchner are guiding you. You need a lot of experience, like in arthroscopy. So a good thing with orthopedics is that we are all trained very well in arthroscopy. And then we detach the disc space from the end plate. As you can see here, we check from time to time with radiology. And the difficult thing is how you insert the big cage, because you have to put it exactly between the four Kirchner. And you see how we take off this glove. I will explain you in a minute. And we insert, as you insert the big cage, this corrects a lot the kyphotic deformity of the spondylolisthesis. One minute. Thank you for your patience. Here, as you can see, because the larger portal for laparoscopy is only 15 millimeters, and the width of the cage is 25 millimeters, this was the main problem. So we identified that we can use a glove, put some sleeping cream, and take out the portal for 1 minute, insert the cage, and then put the portal back again. We don't lose a lot of pneumatic pressure. So this solved the problem of the very large cage. And as you can see, because of the lordotic form of the cage, you have released all the posterior area here, then you have a good correction. And the final correction, you have it with the posterior. You see one of our main spondyloptosis cages. So you go first and posteriorly, and we actually did this case together with Yannis Polythodorakis in Athens area, because this was a patient, an athlete patient from Athens. And we took completely all the posterior instrumentation. We inserted the screws. And as you can see, there is a huge correction of the kyphotic deformity. And it was measured here 40 degrees. And then we have 10 degrees of lordosis. So we had a correction of 50 degrees in total. And this is the patient. She's a Taekwondo athlete, and she took the silver medal in the European Games 3 years later. Thank you very much.
Thank you, Vasilis, for your nice talk. And we now continue. Dr. Saud, are you going to present the next speaker?
It's my great honor, actually, to present our first keynote speaker for today. And it's on techniques of correcting AIS. Actually, it's very difficult to present Professor Christopher Schäfri, one of the true mentors and heroes of spine surgery of all time. He's the chief of Duke Spine Division, world-renowned pioneer of pediatric and adult deformity surgery and spinal cord injuries and so many other topics. He's the president of IMAST and the president-elect of American Association of Neurological Surgeons and director of American Board of Neurological Surgery. It's very difficult to introduce you, sir. So if I missed something or a lot of things, just excuse me. And we are looking forward to your talk. Go ahead, sir.
Vasilis, please unshare your screen.
Do that. I'm sorry. Okay.
Thank you.
Thank you for the exceptionally generous and gracious introduction. So a little bit, I was asked to talk about AIS, and let me see here. There's something going on. Share screen. Hold on, I'm having a little trouble with the share screen aspect. Let me try again. Files. Let's see if it'll... Somehow it is saying Zoom is not allowing me to share the screen, which is funny because I share a screen with the Zoom all the time.
Chris, can you try again? I've just changed the setting to many people to share at one time. Maybe there may be a glitch.
Okay, let me restart again. Yep, I sure will. No, that's not working basic.
Imad, can you check at the same time, please?
You know, I'm just wondering if there's some kind of block, because we do a lot of Zoom for patient care now, and I'm wondering if there is some kind of screw up with the Zoom that I have. Hold on one second. I'm going into my system here. If oh, hold on. Let me just do this. Privacy. Hold on. 3. Okay.
You may have to just restart Zoom. That may be there may be a glitch there.
Yes, it says Zoom will not able. Yeah. So I'm gonna have to quit. I'll be right back.
Sure.
Okay, maybe what we can do then is while we wait, if there are any people who have questions for the previous speakers, if you could just enter the questions into the chat function. Just type in your questions and we'll go through a couple of questions till we see Chris back. Or if any of the people who have been allowed to speak have questions, like any of the people who can, because some I know can't unmute. So if any of the faculty have questions, they can ask. Oh, here's questions. Okay, not yet.
Maybe I can ask a question to Ahmed Alani regarding the new technique that we are thinking may be the future. The question is where Ahmed, are you there? Can you just unmute yourself?
Unfortunately, he has gone. He has
okay.
another commitment
Okay.
at the same time.
He
said he can answer the questions via email.
Okay, maybe I can ask you this question. Where do you see this procedure going, Mehmet?
He's doing the
Oh, here we go.
just in Istanbul. He
Okay,
has
no-
more
no
than
problem.
150 cases.
okay,
no problem.
all right, so we
There is
have,
a question from Paulo Pereira, I think, to Vasilis. Laparoscopic ALIF looks quite complicated technically. Do you really see an advantage comparing to traditional retroperitoneal ALIF? I was going to ask the same question, by the way.
Yes. If it is really an ALIF in big, large cage, it is a little bit easier only in comparing with the vessels. You have a straight procedure. You don't have a problem to insert the cage, but I don't really see a big any other differences. I'm not
Imad,
familiar.
Imad, can you unmute?
unmute Dr. Shafri?
It just happened. I'm
Okay,
now
good.
unmuted. Thank you.
Okay, all right, so yeah, okay, we'll move on to Chris's talk. Okay, thank you, Chris, for getting reconnected.
Yeah, thank you. I think it was a glitch on my end, so I had to reset my preferences. So good morning, afternoon, and evening to everyone, and I am really honored to be asked to speak about this. You know, in reality, I do about 90% adult deformity and about 10% pediatric. So some of the other wonderful speakers we've had are probably far more knowledgeable, and I'll give you my kind of rudimentary learnings, what I've done over the years to try to go and be a better adolescent idiopathic scoliosis surgeon. These are my different disclosures, and the two major ones is I've worked on developing pedicle screw-based systems, mostly deformity systems for both Medtronic and NuVasive. So this was how I did surgery 5 to 10 years ago. This was a presentation that I had done, and I found it. I found it interesting when I was looking through to make this presentation, how things have changed and how I can do things in a much better way. And I want to sort of impart some of the techniques and differences that I've changed over time to help people at least consider something that they may do. So this was a 13-and-a-half-year-old young lady who had some backache, but had progression of scoliosis. She was treated in a brace and failed the brace, and she went from about 35 to about 55 degree curve. And as you're going to see, not only had the curve progressed, but she also cosmetically really did not like the way that this curve appeared. So one of the first things that we do, you know, again, and I saw the use of supine x-rays. These are supine side bending x-rays showing that this is when we go and do classification, that this is a Lenke 1A curve. And one of the things that we always want to look at is both clinically and radiographically the positioning of the shoulders, whether the left shoulder is low, neutral, or high, and particularly with a right thoracic curve. So the preoperative clinical evaluation, you can see why she was unhappy with the way things appeared. This is showing her chest wall abnormality and showing again why this is a cosmetically displeasing case. So one of the first things which I always think about is where I stop and start the instrumentation. I've got to say some of this information from Larry Lenke, and what's happening is that for me, when I'm asked about it, that's the most common question I get is somebody will send me some x-rays and say, how high should I go and how low should I go? Doing the stuff in the middle, kind of straightening stuff out, I think most of us as spine surgeons have some concept for. So what I do is do a standard classification and determine which regions are likely to be fused. Then the next step is determining the upper instrumented vertebrae and the lower instrumented vertebrae. If you're going to do anterior surgery, generally you're fusing from end vertebrae to end vertebrae. But for posterior spinal fusions, this is a bit more controversial. So I think the standard classification is the really great one by Larry Lanke. And what this does is assesses whether the different curves are structural or non-structural. And it takes into consideration the deviation of the apical lumbar vertebrae in a prediction as far as fusion levels are concerned. And it takes into consideration the thoracic profile, and it gives an idea about what levels of the spine to be fused. And you generally want to fuse the structural curves from end vertebrae to end vertebrae, but there's a little bit of give, particularly if you're trying to do a selective fusion versus doing a complete fusion. And for young people, for all of us that do adult deformity surgery, we see an awful lot of people who had fusions as an adolescent who are very, very unhappy in their 40s, 50s, and 60s. So the goal is to have a balanced and compensated spine and limit the fusion as much as we can. So basically, when we're looking at the upper instrumented vertebrae, what we have to look at is whether the shoulder is high, whether it's balanced, or whether the right is high. And we want to go and assess very carefully the size and stiffness of the proximal thoracic curve. And if it's structural, that has an impact, and you're going to fuse in through the structural curve. It also, you have to assess on the lateral radiographs whether the proximal thoracic region is in normal alignment or whether it's hyperkyphotic. And then you also have to take into consideration the amount of main thoracic correction planned. And what's going to happen is the more correction you have, the more you're going to drive your left shoulder to a higher level. So basically, if you have somebody who has a left shoulder high preoperatively, you have to go higher, and this is generally to T2. If the proximal thoracic curve is structural, as you can see in this case that it is, with the bending film, it only improves to 50 degrees. If there is going to be planned to do a marked apical translation, which in this case there is, and if there's proximal kyphosis, in this case there wasn't, but there were the other factors. There are people that you're going to want to go up to T2. When you want to go up to T3, when you can stop it a little bit, this is in generally cases where the shoulders are level, or a slight right-sided shoulder elevation. You're going to raise the left shoulder by correcting the main thoracic curve. You have, in this case, the proximal thoracic curve is somewhat structural. You're going to plan a marked main thoracic curve, and there's only, in this case, minimal to no kyphosis. And if there's kyphosis, again, you would go up to T2. For T4 and 5, you have the right shoulder high preoperatively. The upper thoracic, the proximal thoracic curve is non-structural. You can see how it bends out, and there's no proximal kyphosis ended. And with these cases, you can have a very predictable outcome as far as the shoulder balance. Now, similarly, for the lower instrumented vertebrae, this is controversial. And if you go back to the time of Harrington, they talked about Harrington's stable zone, that you wanted to fuse into the stable zone. And then with the King-Mo, which brought into consideration the center sacral vertical line, which they talked about the stable vertebrae. And you can see the stable vertebrae is the one that's transected by the center sacral vertical line. And then Sook had an end versus neutral vertebrae. This is the end vertebrae. Which is the Cobb angle. The neutral vertebrae is the one without rotation. And you can see that there was an analysis in cases when you could end at the end vertebrae versus ending at the neutral vertebrae. And then Larry Lanke came up with what he calls the CSVL touching lines, and you're going to see this. And this is Larry's work. And it showed that he went and showed 40 cases of AIS to 17 senior SRS surgeons, and the overall agreement was relatively poor about where to end a vertebrae. So basically, if you have a lumbar A modifier, you can go to a shorter length of construct. And in this case, what you do is you do the most cephalad vertebrae that's still touched by the center sacral vertical line. If you have a B modifier, you want to have it more than touched and heading towards having it bisected. And then finally, with a C modifier, you need to have the last vertebrae that is completely bisected by the center sacral vertical line. And this is generally the stable vertebrae. So, but with that, you can go and do your different predictions. Here's somebody with a 2AN. So you've got a structural proximal thoracic curve, and again, using these different rules, showing the surgical correction that is needed. So finally, a lot of times, again, when you have more complex curves, there's involvement of the lumbar spine, either lanky 1CNs or lanky 3 curves. You're going to have to determine whether you can stop at L3 versus L4. This is a common decision-making area. And what's happening is when you can stop at L3 is if the L3 vertebrae has limited rotation, so no more than a grade 1 NASHMO rotation, that the L3-4 disc is neutral or reversed, okay, so that it's beginning to flatten out, and then that the apex of the thoracolumbar curves is L1 or the L1-2 disc. If it's below that, then you have to go down to L4. And by doing this, again, you can relatively predictably pick and have a well-balanced spine. Now, if it doesn't have those, if the rotation is greater, the disc is not neutral or reversed, or the apex is at L2, as in this case, or below, then stopping at L3 is just not going to work. And because of that, you need to go down to the L4 4 level. So basically, you want to look at the shoulder balance, the structurality of the proximal thoracic curve, the amount of correction of the main thoracic curve, and the lower instrumented vertebrae depends upon the CSVL touching line. And again, what we're trying to do is trying to push towards less. And every once in a while, particularly those with a lot of growth remaining, you could end up having to extend your fusion. So this is a case. That from about 7 years ago, and this is my analysis of this case, showing that it's a lanky 1A curve that shows the side bending radiographs and the supine radiographs, and shows the relationship. And you can see that the CSVL is touching the L1 vertebrae right here. So when we're talking about a correction strategy, what I did years ago was generally I was putting screws in, and the density of screws is a little bit, again, another area of controversy, and I don't have that long to talk, but I generally would put a fair number of screws in, not at least one pedicle screw at every level. And so what's happening is that I would put my convex rod in, then I would put my concave rod in, and using it as I'm doing that, cantilever the spine over to be able to get the correction. I would compress over the convexity of the deformity and sometimes tweak it with a little bit of distraction across the concavity. And then the final major portion of correction was a segmental derotation maneuver using a linked system such as this. This is from Journal of Neurosurgery, spine describing using this type of a derotation technique. And so basically, this is what we're doing. This is the girl. This is the X-ray. This is my surgical plan, because the shoulder was the shoulder thing. I put a proximal thoracic, a transverse process hook. This is positioning. This is interoperatively to make sure that my trunk balance was good. And you can see this is an X-ray taken with sort of a T-square to make sure that I'm happy because there was a little bit of obliquity of S1 with that. This is a result I got. And, and the fact is it's okay. But one of the things is you look, she's got some cervical kyphosis. That cervical kyphosis is likely a byproduct of her scoliosis, but also my sagittal plane correction in this case was not very good. She's got a pretty flat spine, hypokyphotic. So what I've done is change my strategies a little bit, and this has been reported in several cases. This was a nice article about the use of reduction screws and how they can be used to achieve better deformity correction. This is another study talking about using stiffer rods and concave side pedicle screw density, again, with using reduction screws to be able to pull the spine up into a more kyphotic posture. So this is a case that I had done about 2 years ago. This was a 12-year-old girl, 64-degree curve. She, again, bends out very nicely. Again, another lanky 1A. And this is my current strategy. So the blue dots are standard multi-axial screws. The yellow dots are reduction screws. So what I do currently is I make a rod which is slightly under contoured for the convex side. I introduce that into the screw heads, and I may use reduction screws at the bottom 2 levels. And with a little bit of cantilever bending and rod rotation, I begin to straighten that out. I compress initially across the convex screws. The next step is I use reduction screws and use a rod that is bent into the sagittal plane, where I put it the top of the rod into the top 2 screws and the bottom of the rod and the bottom 2 screws, and out throughout the middle I use reduction screws. And I use a rod which has a squared geometry. That the top and bottom are rounded, the sides are flat. And with the reduction screws, as it pulls the spine up to this, it really does a tremendous amount of derotation and allows you to get away without having to do a complex manual derotation. You may want to tweak a little bit, but you don't. The major amount of correction is done through the instrumentation. So that pulls that up. And so this is intraoperative X-rays showing what things look like. And this is her now at 2 years. And if you look here, that her thoracic kyphosis, I feel, is at the low normal level. And you can see that she was also somebody who had cervical kyphosis, and her cervical alignment is returning back to normal. So these are some of the techniques that I use. I'm not the world's most sophisticated deformity surgeon in the pediatric world, but this has allowed me to get very predictable results by doing the analysis and using these surgical techniques. Thank you.
Thank you very much, Chris. As always, an excellent talk. Given that we're running behind, I think we'll have to skip the questions. If people have questions, put them on the chat, and we will forward the questions to the speakers and have the speakers respond by email. So let's move on to the next session now.
Yanis, can you introduce the next speaker, please?
I'm going to present Professor Zizaleli. He was professor of neurosurgery in Ege University. He was founding president of the spine section of the Turkish Neurosurgical Society, and also president of the World Spinal Cord Society, and as I remember, also of the Middle Spine Society. And he's a great teacher, and I want to introduce him for his talk. Dr. Zizaleli.
Hi, how are you? Do you see my screen now?
Not yet.
Yes.
No, it's, I think
It's
It's
quite
there, but it's
dim.
dark.
Dark, very dark.
Very dark. Is it okay?
we can see
No.
it as a background, not yet as a full screen thing.
I'm changing and it looks like I'm okay.
That's not what we're seeing.
Yeah, Mehmet, we are seeing it, but there is something like it's in the background, not something that we can see clearly. It's a background thing.
Oh, there we go. We got it now.
Is it okay?
Yep, it's perfect.
Good. Yes.
Okay.
My topic will involve the pre-optimization of deformity patients. So this is actually, we have to prepare our patients before surgery. In fact, if you look at the adolescent idiopathic scoliosis and congenital scoliosis, we can have concerns only with the respiratory problems in very severe cases. Otherwise, in most of the cases, as you have seen in the previous speakers' cases, there is no problem. So there is no need for any preparation. But if the kyphosis or severe scoliosis have caused some restriction in respiration, some surgeons prefer to do some tractions before surgery to get their lung capacity better. But this is all I can say about this. But most of the thing is the adult degenerative scoliosis or kyphosis, since those cases have premorbid diseases and osteoporosis and frailty and immobility, we have different tasks to prepare those patients for our big surgery. If you look at the complications of adult deformity surgery, complication rate may reach up to 80%. Pseudoarthrosis is very common, and reoperation rate is approximately 36%. Then the reasons of reoperation are pseudoarthrosis repair and need to lengthen the fusion. If it is together with an osteotomy, the deformity correction, the total major complications reach up to 42%, and the risks are much in older ages, in two-level osteotomies and thoracic osteotomies. In general saying, weaker bone, osteoporosis, and more deformity and more comorbidities are the main problems of adult deformity surgery. And these are the complications. Actually, most common one is the adjacent segment disease. It may be cranial or caudal level. And one of the most common complication is the proximal junctional kyphosis. But however, it can also happen in the caudal level, especially in L5S1 problems. Sometimes if our fixation is very rigid, then sacral insufficiency fracture and hip disease may happen. Instrument failure and pseudoarthrosis and systemic complications are other reasons of complications of adult deformity. To avoid systemic complications, major blood loss may not be tolerated by the elderly. This is a main concern, actually. In case of major systemic diseases, especially in cardiac disease patients, simple decompression and limited fusion may be preferred in some cases. Although it is a suboptimal treatment. Recent trend, because of that, is the MIS surgeries. And this study is giving in a retrospective nature, postoperatively 65% reduction of VAS if it is done endoscopic foraminotomy in patients with moderate degenerative deformity. As you can see, it is not very optimal. In MIS surgeries, complication rates may go down to 14% in comparison to open surgery. However, those authors also say that severe deformity better corrected with open surgery. Post-op VAS and OD scores are same. This study also stressed the MIS techniques are useful, especially posterior MIS screws and lateral transpsoas fusion. However, open techniques should be preferred if SVA more than 100 millimeter, if more low doses correction necessary, if osteotomy necessary. One another thing that we must have concern is the frailty of the patient. So then the in gerontology journal, it was defined 3 types of frailty status: robust, prefrail, and frail. So if we look at this study from 2018 in a retrospective nature and the surgery after thoracic or thoracolumbar trauma, the complications in frail patients are quite more common than non-frail patients, and 30-day mortality rate in frail patients has been found 16% in comparison to the non-frail patients, 0.6%. So the geriatricians has defined some characteristics of the frailty criteria with the weight loss, exhaustion, low energy expenditure, slowness of the patient by measuring the gait speed, weakness, grip strength, and then robust, intermediate, and frail. If the patient is frail, that patient must be pre-rehabilitated before surgery. Otherwise, you can correct the deformity, but you will get not a good result. This is a table that we can define more. If there is severe osteoporosis, some surgeons use teriparatide or more mobilization before surgery to prepare the patient for a better result. If there are premorbid cardiovascular problems, less bleeding, less invasive surgeries, and fixations as short as possible are some measures. Lack of mobility needs rehabilitation, and depression and delirium needs psychological support, less or no methylprednisolone usage because they may increase the postoperative delirium incidence, mobilize early with an orthosis, decrease delirium-inducing medications, use haloperidol or quetiapine to treat delirium and agitation. We have summarized some of these in World Neurosurgery last year. Adult deformity, to operate or not operate, high complication rates may reach up to 40%. Reoperation rates 1 out of 3 per patient. To avoid systemic complications, we must have less bleeding. We can try MIS techniques. Treat osteoporosis with preoperative osteoporosis medication. Use cement augmentation for osteoporosis. Tell the patient for very high complication rate and reoperation rate. Apply early mobilization and rehabilitation. We must also use psychological support and antidepressive and decrease delirium-inducing medication. We must be aware that we can have a very nice radiological views at the end, but the patient may develop delirium, depression, and psychosis. But the patient may stay immobilized, maybe frail, exhausted, and a very bad result. Thank you for listening to me.
Thank you so much, Mehmet, for the nice presentation. We would move on for the next speaker. Our next speaker is a great friend and a great educator and a great mentor, Dr. Jason Savage, consultant spine surgeon in Cleveland Clinic and associate professor of orthopedic surgery. Had his fellowships in University of Wisconsin and Northwestern University. He's a great educator and a great surgeon and a great friend. We would enjoy so much listening to his talk about building a spine deformity program. Jason.
All right. Well, thanks, Obad. It's good to see you, my good friend. And good morning, everyone, or I guess good afternoon or evening, depending on where you are in the world. I appreciate the opportunity to talk. So I want to thank all the co-directors, course directors for the opportunity. So I think this topic in terms of building a spinal deformity program is probably perfect to follow Mehmet's talk because I think, building a deformity program, probably 90% of it revolves around trying to, optimize these patients actually prior to surgery. So some of this will be a little bit of an overlap, but I'll kind of just give you kind of our experience, particularly Doug and I's experience at the Cleveland Clinic and trying to develop one of these programs. So in terms of disclosures, these are my disclosures, none of which are relevant to the contents of this talk. But I will tell you that, we're still in the process of building our program. Doug's been doing a lot of deformity at the Cleveland Clinic for probably 18 years now, Doug, right? And I've been there for 5 years and we do 6 years. And we do a fair amount of deformity, but we're really honestly still kind of in the process of building this program. So I'm going to kind of talk a little bit about some of the trials and tribulations that we've kind of ran into in trying to do something like this. So for everyone on this call, just as a brief introduction, the good and bad news, because we all like to do deformity surgery, which is why we're kind of participating in this meeting. The good and bad news is that we're just going to get busier and busier as time goes on. The population age 65 and over is projected to double by the year 2050. For the first time in US history, at least in the United States, older adults are projected to outnumber children by the year 2035. And what we know about these patients is that about 30 to 50% of patients over the age 65 develop a curve. Doesn't mean that all of them, develop a significant curve or a clinically significant curve that needs surgery, but many of these patients will go on to have pain and disability associated with their adult spinal deformity. I think over the past probably 15 years, 10, 15, 20 years, we've really focused a lot on trying to collect data on these patients, understanding kind of what the preoperative, alignment parameters are that are important, some of the preoperative optimization, obviously, that Mehmet talked about. And I think the data would suggest that outcomes in adult spinal deformity surgery are generally favorable if done for the right reasons and if done well. I think sagittal plane imbalance is one of the main drivers of pain and disability. But I think what we're learning really now, particularly with artificial intelligence and machine learning and looking at big data, is I think we're going to get a much better understanding of kind of the nuances and kind of the little aspects that really impact the outcomes of this patient population. And I think in general, if we restore spinal pelvic balance and harmony and use age-appropriate alignment objectives, this leads to improved outcomes, right? So patients like this who come in, who have a really severe, profound degenerative scoliosis, when you correct them, for the most part, they tend to do very well. But, and this is really kind of what Mehmet was talking about, and he very eloquently did so, the overall complication rate with these surgeries is relatively high, right? It could be up to 40%. Major medical complications occur in 15 to 20%. Neurologic deficits in 3-column osteotomies have been reported to be up to 25%, and so on and so forth. So I'd kind of make the argument, and this is what Mehmet was saying as well, is that, I think the technical aspects of surgery are really important, but I think the preoperative assessment optimization are probably even as important, if not more important, and particularly this patient population in terms of trying to kind of optimize their outcomes with these kind of bigger complex surgeries. So that kind of brings us to kind of the crux of the topic of this talk in terms of trying to create a deformity program. I think you really need a multidisciplinary approach to high-risk spine patients. And by no means are we the first that are trying to do this. You know, Raj Sethi in Seattle and Tyler Koski, who is a good friend of mine in Chicago when I worked at Northwestern. They were two of the first real people to kind of write about this, publish on it, and talk about the need for developing like a real true kind of program, a multidisciplinary program that kind of looks at all the aspects that go into trying to get these patients through surgery in kind of an efficient, safe, and optimal way. And kind of all of these programs, if you look in the literature, you know, they include a multidisciplinary team pre-op screening conference that really helps identify high-risk patients. They talk about standardizing protocols for patients with deformity, and that's perioperative medical assessment and optimization. It's intraoperative fluid and blood management programs. It's postoperative pain control and mobilization. And a lot of authors have commented on, if you can do this and do this well, it definitely improves patient outcomes and decreases the risk of perioperative complications. So in terms of developing a deformity program, and this is kind of in my relatively simplistic mind how I think about this, and Doug and I are really kind of trying to put this together at the clinic. Step one is really to recognize the importance of developing a true program, you know, that focuses on the care of adult spinal deformity patients. I think most of us on this call would kind of agree that centers who are doing this in high volume probably do a little bit better of a job. And it's not necessarily just talking about the surgeons. It's the anesthesiologists, it's the medical doctors, it's the rehab physicians, it's the pain psychologists that really understand the complexity of this patient population. So I think you have to recognize the importance of actually doing this. Step two is identify the people who are really critical to the success of the program. And obviously as deformity surgeons, yeah, we're part of that team. We're the leader of that team. But we kind of play a relatively small role, I think, in that team. You know, so you need to get your anesthesia team together. You need to get your bone health team together. You need to get your perioperative medicine team together and kind of get them, because they don't understand. They don't understand kind of what we're trying to do and kind of the complexity in this patient population. So we have to kind of educate them about that and kind of really explain to them what the goals are here in terms of kind of putting this program together, and then finally convince them that it's important. You need really 100% buy-in, and that's probably the hardest part. So the way I think about this, you know, as the spine deformity surgeon, we are, at least to use an American kind of analogy, we're the quarterback. So if you look at American football, right, we're the kind of the quarterback of this team. And we have to be, because nobody else cares as much as we do about these patients and about our outcomes and about kind of how we get these patients through surgery. But a lot of other people are important, right? So perioperative medicine team, I think in an ideal world, and we have failed to do this yet in Cleveland, but in an ideal world, there would be a very specific team that included, you know, a handful of medicine doctors who truly just kind of did the preoperative evaluation and kind of perioperative kind of management of these patients, even on the floor. We had that at Northwestern when I was there, and it was actually a very, very nice kind of system where we're trying to kind of build that at the clinic, but there's definitely been some roadblocks. But we do have a very kind of, you know, obviously well put together kind of perioperative team who does all of our preoperative evaluations and obviously kind of helps manage people in the hospital. Neuroanesthesia, this is critical, right? So you need a neuroanesthesia team that really kind of, you know, develops protocols, develops algorithms in these complex spine patients who you know are going to lose a fair amount of blood. And it's amazing. And Doug and I have seen this, you know, probably weekly, whereas if we have one of our neuroanesthesia team members who are part of our team, the patients just do dramatically better. They get extubated. They go to the floor post-op, as opposed to if we get an anesthesiologist who's not part of that team, oftentimes they're making a decision to keep them intubated and go to the ICU before we even start the surgery, right? So I think it's critical to kind of have a team and a neuroanesthesia team that kind of understands the goals and how to get these people through surgery. The endocrinology and bone health team, I think, are incredibly important. And I know Mehmet mentioned this. I think one of the challenges that we have as adult deformity surgeons is dealing with osteoporosis and kind of trying to prevent all the complications that go along with osteoporosis and these bigger surgeries. One of the things we've done is actually we have a rheumatologist in our department who is mostly doing medical spine stuff, but we actually talked to him about doing bone health, and now he's transitioned about 50% of his practice just doing bone health evaluations for our high-risk spine patients, our deformity patients, and is kind of helping with the process in terms of trying to figure out, you know, what the best treatment for that is, including, you know, anabolic agents, which a lot of us obviously want our patients on prior to surgery. And then pain psychology and kind of cognitive behavioral therapy. This is kind of the big elephant in the room, but I think it's incredibly important to have a good team of pain psychologists that can help kind of patients get through this process a little bit easier. And then not only is it these four groups of people, there's a lot of people, right? There's a lot of prehab that goes involved. There's a lot of post-rehab that goes involved. We actually found that a large percentage of our elective spine patients were coming into surgery anemic. So now we're obviously kind of checking their hemoglobins and hematocrits 30 to 45 days even before surgery. And if they're below 10, we're sending them to blood management and delaying their surgeries. Nutrition and bariatric surgery, obesity is a big problem everywhere probably, but particularly in the United States. So we have a relatively strict cutoff of less than 40 BMI, but these patients need to go to get a multidisciplinary kind of weight loss program before they have their surgeries. There's no question. And obviously cardiology and so on and so forth. So in terms of minimizing complications, this is a surgery I did this week. These are big surgeries, but I think, what are we trying to prevent? We're trying to prevent perioperative medical complications, infections, neurologic injuries, which is obviously on us in terms of a technical aspect of things, and then reoperations. So in terms of developing a true deformity program, these are kind of the things that we have thought about in terms of preoperative kind of considerations, intra-op and post-op. Pre-op, you need a triage system. You need to create access for these patients, right? So what we've done at the Cleveland Clinic is that we have 2 or 3 triage nurses that basically kind of help triage all of our patients. And it took a while to kind of, work out the kinks, so to speak, in this process. But right now, it's a relatively well-oiled machine. We get imaging reports kind of sent in. The triage nurses call patients. They do intake forms. They kind of figure out what their issue, what their problem is. And then if it's a deformity problem, that for the most part gets sent to 2 or 3 surgeons at the clinic who really focus and specialize on deformity. What I'm trying to do now, and I've realized, and I learned this the hard way, is these deformity patients, right? They don't take 10 minutes in clinic. They take 45 minutes to an hour in clinic. So if you kind of just plug in some deformity patients in your already busy clinic, it's very challenging to kind of, pay attention to the detail that you need to for these patients and spend the time with them. So now I'm trying to kind of create 2 to 3 half days a month where I just see deformity patients and have those slots be longer so I can kind of, take the time that's needed. And you kind of want to, if you're going to develop a program, you got to have kind of a white glove service. So what we're trying to do is basically kind of try to tell people, look, if you have a patient who has a deformity problem who needs to be referred to our center, we will kind of guarantee to get that person in within 1 to 2 to 3 weeks of that referral. And Doug and I have worked very hard in trying to do that, particularly with kind of our referring physicians, but even our referring surgeons. There's a lot of people on this call, particularly Chris, if he's still on, knows that, most of our practices are actually kind of referrals from other spine surgeons who kind of say, maybe I should refer this on to someone who's doing a little bit more of it. So I think marketing is important. Obviously, if you're developing a program, you got to let people know that you're actually doing it. I think you should kind of let your outcomes and your results probably be your biggest marketing. But at the same time, marketing is important. Education and counseling, incredibly important. So your nurses, your APPs, obviously your outpatient team needs to kind of get a good understanding of what these patients are going to go through, because I think the preoperative counseling part is incredibly important. Obviously, Mehmet talked about the medical optimization, which I think is incredibly important. And then a case conference, and we do case conferences every Friday. They're not necessarily all deformity conferences, but we're trying to kind of carve out a conference per month that we just talk about deformity patients that are scheduled basically for the next month. So we can kind of go over surgical plans, we can discuss what the options are, and then we can kind of go through this checklist and make sure that everyone has kind of gone through the appropriate optimization before they actually get to surgery. I think the elephant in the room is chronic pain, at least in the United States it is. So we're working really hard right now to try to develop pathways for optimization of chronic pain patients. We're still kind of working on this. We don't have all the answers. We do have a preoperative kind of pain class that's led by our pain psychology team. And actually, we just started enrolling our first patients this month. So all of our deformity patients are going to be taking this class. It's about a 2.5 hour class that's offered as a group virtually. And that's going to kind of become standard of care. In terms of intraoperative considerations, we talked a little bit about the importance of neuroanesthesia and getting them on board. Our anesthesia department, we're lucky at the Cleveland Clinic, but they're very good. And then they understand it and they get it. And they developed protocols in terms of specifically taking care of these patients. I actually have this information. If anyone wants it, you can feel free to email me. I'm happy to provide it to you. Obviously, your neuromonitoring team, you kind of got to get a good sense of, all right, when, why, and how are you going to monitor? And then have a really good algorithm for abnormal alerts. Obviously kind of use your blood salvage, when necessary. And the deformity correction part, and this is on us. I mean, I think we have to get this right the first time, and oftentimes it's hard. But I think, understanding the age-appropriate alignment objectives, appropriate handling of and choice of implants and soft tissues, decreasing length of surgery, decreasing EBL, all of those things really kind of significantly impact the outcomes of our patients. And then post-operatively, obviously, multimodal pain management. Some of our surgeons are using epidural catheters. I don't think Doug and I are, but
I use them extensively.
Yeah, so epidural catheters are a really good way to kind of help with perioperative pain. There are some potential side effects of using epidural catheters. PCAs, oral narcotics, muscle relaxers. We've actually been using Toradol, which is a little bit of a controversial topic from fusion rates, but we use low dose Toradol for 48 hours. Early mobilization. This is just this graphic right here is something that was put together by one of our physical therapists, and it shows that if deformity patients are seen on postoperative day number 1, their length of stay is dramatically decreased as opposed to kind of being delayed in terms of starting their mobilization. So we get these people up as fast as we can. So, just to summarize, guys, I think it's really important to recognize the importance of developing a program. I think you need to identify the people who are critical to the success of the program, and you really need to have buy-in. It takes a lot of time outside of the OR and outside of clinic to put these programs together, and we're learning that the hard way. Let your outcomes be your biggest marketing tool, but I think marketing is important. And then collect data, report your successes, and report your failures. And I think the more we do that, the better we're going to get. So thanks, guys. I really appreciate the opportunity to talk.
Thank you, Jason, for the very interesting talk. And for those who didn't visit Cleveland Clinic yet, if you want to really build a program or see how people work properly in a group, this is the place to go to and see if things would go your way or not. So thank you so much for the great experience, Jason, and it was a beautiful talk. Let's move to the last but not least speaker or keynote speaker, Jean-Charles Lewak. Professor Lewak is a great friend of me and of a lot of speakers and faculty in this society, and a great friend of the society as a whole. He was the vice president of this society until he was too busy to complete the journey with us, but he had a lot of leverage for this society in the beginning of its work. He's the chief of spine unit and chairman of Department of Orthopedic Surgery in Bordeaux University Hospital, director of Lab of Surgical Research in the same university hospital, member of French College and Society of Orthopedic Spine of Orthopedic Surgery of France, board member of Spine Society of Europe, and as I said, the past vice president of our society. Is going to address us on preoperative planning of intraoperative assessment in sagittal deformity, and he's a pioneer of this. He is one of the best surgeons around the world who would give you a real idea about sagittal balance, its importance, how to deal with it while dealing with deformity patients. So we are so much looking forward to your talk, sir. Go ahead.
Thanks a lot, my friend. It's a great pleasure, and thank you for the nice introduction. You always say too much about me, but it's a real pleasure. So I will share my screen now. So pre-op planning and intra-op assessment is something which is very important in our daily practice. Oops. My disclosures. So the first step, of course, is to try to analyze the deformity, to analyze the balance in the frontal and the sagittal plane. So the sagittal balance analysis of scoliosis, you have to know all those parameters we spoke about, the pelvic parameters, the spine parameters, the correlation between them, and the compensation phenomenon, which is, I think, the most important, as the majority of the patients we treat are not the young patient, but old one. or at least more than 40 or 50 for DJ and SCORI, and those have already compensation possibilities that they can use. So like in this case, where we have a compensated imbalance, of course, the C2 vertical line should fall through the femoral head. This is the way you have a balanced spine. It's not, of course, economical balance because the patient will need to use his posterior muscle in the thoracic area, creating a thoracic lordosis in this case with a short lordotic segment below this kyphotic lesion. But anyway, in this case, the patient is still balanced. It's a compensated balance. Even in this case, the vertical line from C2 falls through the femoral heads. So another case here, which is a compensated balance, and it is imbalanced in this case. It's not balanced anymore because the C2 is a little bit in the front of the femoral head, not already, the drawing is not correct, but it's a fixed thoracolumbar kyphosis, loss of lumbosacral lordosis, and pelvis retroversion. We see the patient is in kyphotic position in the lumbar spine, but the C2 vertical line is almost in good position. So it is not economical, but still balanced. Here it is decompensated. The vertical line from C2, which represents the gravity line, is far in the front of the femoral heads. So when the pelvic retroversion is at the maximum, extension, the next step is the flexion of the knees. And the rigid kyphotic spine, the lower limbs compensation, cannot correct this. And the patient is in this situation. So for instance, for this case, we need to restore a good lumbar lordosis. We know that, and that way the patient will have extension of the knees, the lower limbs will be straight, and with this construct, which is not too complicated, but anyway, it is a PSO at L4, we restore a good balance with the vertical of C2 falling a little bit behind the femoral head, which of course is very good. Another case here, 58 years old, 3 years post-op, with a long construct just to restore the balance. Fixed imbalance with degenerative changes. Also, we have to pay attention to the coronal imbalance. And the balance could be on the concave side or the convex side of the deformity. And of course, the way we need to correct it is totally different, because on the left side, where it is on the concave side, you have to do a PSO just below the deformity here. When it is on the convex side, you have to do the correction in the bottom of the deformity at the lumbosacral area between 451. So it's not exactly the same strategy that we have to use. So the potential imbalance, like in this case, you have the frontal and the sagittal. And here you have to combine both, because you have to correct the coronal plane and the sagittal plane at the same time. And in this case, of course, the best is to work at the level L4 to correct the sagittal imbalance. But on the coronal plane, you have to correct it with an asymmetrical PSO at L4 to correct the deformity, like in this case. So we do this in 2 steps using those connectors to correct first the bottom, to have the spine straight between 3, 4, 5, and 1 with iliac fixation. And then we correct the deformity on top, and we connect with the connectors just to reduce the imbalance at the same time. So convex imbalance correction with asymmetrical TLIF, which is possible when it is still possible to mobilize the disc. So you put the cage mainly on one side so that you can correct the deformity, but sometimes it's not enough because the deformity is too much and you have to do this asymmetrical PSO. Those drawings are from Daniel Chopin, who was my mentor to teach me about this, like a patient in this case. This situation, so you have to correct the coronal and the frontal plane at the same time. So you need to plan this. You need to plan the correction with asymmetrical correction and it's possible to have a very good correction. Of course, it's a long surgery. This is the reason why it's very important to plan the correction before and to check on your different softwares available today if you can do it properly. And you will have to do, of course, the analysis of the deformity before analyzing the flexibility of the curve in lateral flexion, lateral bending, and also flexion extension images. But it is possible to combine both to do that. But without a plan, analyzing the coronal and the frontal plane at the same time, it's not possible. You need to simulate the correction before the surgery. Otherwise, during the surgery, it will be very difficult to analyze exactly what you have done. So the surgical strategy for deformity, you need to have sagittal and frontal plane. The surgical treatment is based on the importance of the Cobb angle, the progression of the curve, the imbalance, the back pain, of course, the radiculostenotic syndrome that you have to treat at the same time, but also the functional limitation like the pulmonary functions, cardiac disease, and other diseases, of course. So for the adult scoliosis deformity, the surgical indication is according to the age. It's not the same treatment at 40 years old and 80 years old, according to general health, and how to find a good compromise for the elderly, of course. When it is at the age of 40, it's quite easy, I must say, because you have to analyze the importance of the curve, the pain progression, and you have to preserve the lumbosacral area to avoid fusion to the pelvis at this time, because those patients are still young and they want to have quite a normal life after that. And the thoracic scoliosis, mainly with persistent thoracic pain, fusion limited to thoracic area, lumbar pain only, no indication for selective thoracic fusion, without sagittal imbalance, avoid lumbar fusion. For those over 50 years old, the progression of Cobb angle, the imbalance, the back pain, and the functional limitation. This paper from De Veren showed that the functional limitations are more important than pain for adult deformity patients when deciding for operative or non-operative treatment. And over 50s, in the majority of the case, you have to do an extensive instrumentation and fusion. So you may just need local economic decompression or limited fixation in a well-balanced, stable spine only, which is not frequently the case. So the balance restoration is essential. And you need to remember some basic principles. Not all the formula you have on the literature, but here I try in a couple of slides to give you what you need to know, what you need to try to restore, but not always completely, because you have the compensation possibilities. And the most important one is the pelvic retroversion. So you all know the pelvic incidence and the pelvic tilt. The best is to try to have a full standing X-ray, but at least from C2 to the femoral head, which is available everywhere in the world. The EOS is growing, and it is very interesting because it's low dose material. So in asymptomatic population, what you have to know, the pelvic incidence, you have to measure it, it's a constant angle. Whatever it stands a little bit in the elderly, we can consider it is constant. The value of the theoretical value of the pelvic tilt is given by this formula. Half pi minus 11 will give you the pelvic tilt that the patient should have if he was 20 years old and healthy. The lumbar lordosis is given from L1 to S1 by half pi plus 28 degrees. And L4 to S1 lordosis is 60% of this one. And what we have seen in the last paper published is that the value of L4 S1 lordosis is mainly almost constant around 35 degrees, which is very interesting to know. So whatever the age, another angle is very interesting. It is a C2HA angle, because this gives you a global analysis of the balance. You take the vertical line falling through the femoral head, which represents roughly the gravity line, and then the dense of C2 to the center of the femoral line. This angle, normally in a healthy population, young, is between -5 and +2, which is very interesting. One angle can give you the global balance. So this is very, very interesting. And how to measure it, I just show you, and it's two lines crossing at the femoral head. This is the normal value. This is the evolution of this angle with aging, of course, due to the disc collapse in the lumbar spine mainly, and also the thoracic kyphosis. The spine is moving forward, and of course, the C2HA angle is increasing dramatically with age. But what is the most important is that in aging asymptomatic population more than 50 years old, but still asymptomatic, this angle stays constant. But if we analyze the spine of those patients, we saw that there is a loss of lumbar lordosis due to the disc collapsing, due to the degeneration of the disc, which is compensated by cervical hypolordosis and pelvic retroversion and decrease of thoracic kyphosis. So that means the patient here in this case is able to keep his balance, moving different segments because they are still mobile, and he has a good global balance. Not the most economical, but he is balanced. And a well-balanced patient has never PGKs, of course. Yeah, but you need to include the C2. The last one, and the last angle you need to know is this one. I call it the CIA, just to kidding with the Americans so that they will remember it. It is the cervical inclination angle. It's from the dense of C2 to the level you want to measure it. So you take the thoracic disc at all the levels from T1 to T12, and you measure this angle from the dense of C2 to the center of the disc you want to measure, and the line which is parallel to the disc at this level. And measuring this angle, which is constant in a normal population, really constant. We did this analysis on 480 normal patients, asymptomatic, from all the countries, all the world. So Americans, Asiatic, Africans, European, Caucasian, and this angle is the same. It's between 75 and 80 degrees. When it is less than that, lower than 70 and even lower than 65, you have always a PGK. So it is a very important angle for our daily activity. Even if you have a forehead posture, which is a compensation phenomenon to try to increase the size of the foramen in the cervical spine, but if your CIA is normal range, you have no PGKs. So that means knowing all those rules, knowing that you have to correct the deformity to decompress the nerve, the planification is very important. And today, I think the most important sentence of the talk is that failing to plan is planning to fail. So 2 steps, pre-op simulation of correction. Not always ideal correction because your patient is old, is not able to support 3 osteotomies, for instance. Using compensation possibilities in elderly is a key. Keeping in mind the rigidity of some segment, if they are already fused, don't cut them, don't try to correct them, just play with them to restore the global balance, to keep your C2HA angle in a normal range. And compromise is the key on elderly. And intraoperative verification. There are many softwares in the world, on the market, on the internet, just to do those corrections. So it's very important. But the key is to keep C2 on the top of the femoral head with the lower limbs in extension. And if you do that, you can do a lot of correction to try to restore the balance. And at the end, your upper instrumented vertebra measure the CIA, it should be in a normal range. Otherwise, the lever arm of the head and the cervical spine will be too high, and due to the weight it has, it will fail after. So this is another one here where they propose you at the end to give you the shape of the rod that you need to correct your patient. There are many on the market. This is the one I use, but I use also another one from Cheops database, which is very interesting because it analyzes not only the sagittal plane, but also the frontal plane at the same time. Here it is with the Cheops. So in this patient, we analyze all the parameters and we simulate the correction with osteotomy at this level. So that way we can correct the pelvic retroversion. And of course, in this case, C2 is in the front. So you have to restore lordosis in the lumbar spine using cages, using other things. But on the flexion extension X-ray, for instance, the thoracic spine was totally stiff. So we don't want to change the shape of this thoracic spine. So to correct this patient, it's better to keep the thoracic spine as it is, to have a less important correction in the lumbar spine at the level of the osteotomy, and to correct the other levels with Smith-Peterson osteotomy on cages or lateral approach with LILIF to correct the lordosis there. So you need to define the compromise which is acceptable for this patient to keep the vertical line from C2 through the femoral head to restore your C2HA angle. And finally, even keeping the thoracic spine straight, you are able to restore a good balance. So in this patient, this is what we did with the PSO at L4 and SPO at the other levels. And the result. Another example with this imbalance on one side and 2 years before. Because the lumbar spine was soft, we decided to correct only the thoracic spine, and you see the realignment, alignment of the spine when you correct the thoracic spine. Another one here, only with the correction in the lumbar area, because this patient is young, and this is an image from Daniel Chopin again, who gave me it. And this patient has been followed now for more than 15 years and still fine. What should not be done is treating a radicular pain by decompression without paying attention to frontal and sagittal plane. Always full standing X-rays or EOS before surgery in case of deformity. This patient, for instance, treated with this mild scoliosis with complete decompression with laminectomy and segmental fixation. This was the first mistake, of course, just below the apex of the curve. So what's happened after a temporary improvement, she had very important pain and she got an extension of fusion, still without full standing X-rays. And the extension of the fusion stopped at the level L1. Second mistake, of course. And after a couple of months, she got a PGK. So now she is in big trouble and you have to treat this intractable pain. So to do that, it will be a long fusion with a PSO and this asymmetrical correction to have a good fusion. So it was better to start with a limited fusion, but including all the deformity in the lumbar spine to treat this patient than to finish with this. What should not be done again, when you have this kind of fusion in a deformity patient, it always failed. So pair-up control is very important. In a simple case, of course, it's easy. Planning on pair-up C-arm control is enough. For this patient with a DDD at L4-5 with modic changes, disc collapse and a bulging disc on one side on the left, everybody will agree probably that you can do only one level fusion. Could be from the front, could be from the back, doesn't matter. You need to plan the correction you want to do. In this case, surgeons decided to do a TLIF, which is a good option. And you see here preoperatively, this patient, if you look at the images on the left, oh, you see it's not bad, it's a good balance. But if you analyze properly, you see that already he lost some lumbar lordosis and he has a higher kyphosis in the thoracic spine. So it's not really an economical situation. So during the surgery, you will restore the lordosis and you need to measure during the surgery what you do. You need to measure the lordosis at the L4, L5 level, which should be around 22, 23% of the global lordosis. So you have to measure it. You can measure it with different apps on the market that use the inclinometer that you have in your iPhone, and you have the angle in between L4 and L5 in this case. And here you have the pre-op and the post-op images. But if you look at it, you say, oh, it's good before, it's good after. Not really. Before it was not perfect. And after the surgery, you see with one level TLIF, you can restore a much better lordosis in the lumbar spine, and the global balance is more economical. Of course, the global balance is good, but it's more economical. When it is a simple deformity, again, planning is important. And here, to use a customized rod for each patient with 3D shape control, like with the KIOPS system that provides you the AP and lateral analysis, which is not the case for the others, you can analyze all the parameters. You can simulate the correction to restore this oblique start, to have a very straight spine between the sacrum and L4-5-1, and then you correct the deformity according to the flexibility of the curve on sagittal and balance analysis, and flexion, extension, and lateral bending. And in this case, for instance, on the MRI, we see that the discs are almost normal for the old patient at 4-5 and 5-1. But the problem is not at 4-5-1. The problem is at the thoracolumbar junction. This is at the thoracolumbar junction that you have to work. You have to restore the normal shape because it is stiff at this level. And we see the patient here is lying on a fulcrum, and you see that there is no change in the curve. So that means it's very important that you make the correction at the right level. So you need to simulate the correction. And here, to simulate the correction, you need to do the PSO at the thoracolumbar level, and not at the level L4 or at the level L3, because it is the level where you are used to do it. You have to do the correction where it is needed. So doing your plan, you will see, as you can see here, that we can use cages from the front or from the back at the level 4-5, at the level 3-4, but you have to do the PSO at the thoracolumbar junction. And you see here that the pre-op analysis, and in blue, you see the rod that was customized for the patient. And here, superimposed, you have the post-op correction 3 years later. And there is no PGK, the correction is economical, the patient is well balanced, and there is no loss of correction. So you see, after the surgery, even when you plan, 8 days after the surgery, the balance is not bad, but you see the gravity line is falling a little bit in the front of the femoral heads. 6 months later, the patient is rebalancing his spine, he's increasing a little bit his pelvic retroversion, but because he has a high incidence, he was able to do it economically, and now he is really economically balanced. So the live control of correction during the surgery is possible with some software. Some are coming on the market. You put those arrays on the key vertebrae on the spine, and you track them with your infrared. So the big companies, they always say to you that you cannot track more than one instrument at a time. This is, of course, totally wrong. If you ask the engineers, how many can I track? They told me 33. How many vertebrae do you have? I said, 33. Okay, we can track them all. I said, I don't need so much. I don't need to have 4, 5, or 6 at the key points. So using those arrays, it's possible during the surgery to put your planning on the left side and to check during the surgery that you restore exactly the plan you have just by tracking those arrays that are at the key vertebra, and you are able to say that the correction I get now, it is exactly the plan I did, so this will avoid to have, of course, problems. So hypocorrection allows compensatory mechanism to keep the gravity line in good position. Natural compensatory mechanism, the pelvis back tilt, the thoracic hypokyphosis, are beneficial, but not always economical, unfortunately. But for sure, hypercorrection creates always reaction in order to try to reposition the gravity line in better position. But if the constraints exceed the bone and tissue resistance, this is the reason why it failed. So the strategy is restoration of good biomechanics, keeping the gravity line through the femoral head, restoring an economical balance using compensatory mechanism, which is very important in elderly. Don't try to restore the balance the same way at 20 years old or at 80 years old. Biomechanical analysis of constraints at the upper instrumented vertebra to determine the risk of failure and using the CIA angle is a good help in our practice. So satisfactory global balance, consider age, physiologic compensation, consider elasticity of lumbar curve and active muscular control, consider elasticity of the thoracic curve, plan osteotomy if rigid, and anterior support because it's much better for the fusion. No overcorrection, because now we see at the beginning I never saw overcorrection. Now patients are referred to us just because they were overcorrected. Always curves harmony. And the most important is L4S1 35 degrees. Global balance correct, head over the pelvis, as Professor Dubousset always said. Thank you for your attention.
And thank you for your presentation. That was awesome. I think Doug Orr is a lot of to talk about and to ask Jean-Charles.
Thank you, Jean-Charles. I always say every time I hear you talk, I need to know a new angle. So this time it's the CIA. That's one I haven't heard yet. Thank you.
It's published in English 3 years ago.
gives you an idea how much time I've had to be reading literature lately. Thank you. Awesome talk, as always. We are a little bit over time, but I think we have some time to do just a few questions. Unfortunately, Jason had to step off. He's got another commitment, but I can certainly answer any questions that anyone would have had for Jason's talk on building a deformity program. So we'll give a few minutes if anybody has questions, if any of the faculty want to chime in, or if anybody wants to put questions on the chat. And just before, the other thing I want to remember that this is only half the program. We will be doing the other half of the program tomorrow morning, same time. You should have the links. We hope it will be as good a presentation or a series of presentations as we had this morning. Are there any questions?
I must say, all the speakers had very good talk. I learned a lot when I was listening to all the talks. Thank you.
Good. Thank you, Jean-Charles. Okay.
So Doug, Mehmet, is it time to conclude?
I think we should, in the interest of getting everybody on with the rest of their Saturday. Thank you, everybody, for speakers and participants for participating. If the participants have any questions, please feel free to put them on the chat. We will put them in touch with the speakers, and the speakers can answer those. Here's the program for tomorrow. A couple of also some of the best speakers, certainly Rick Fessler and Richard Asseker are two of the best speakers out there. And so I strongly encourage everybody to come and listen tomorrow. Thank you very much, and we will see you tomorrow.
Bye, friends.
Bye. Thanks again,
Bye.
Jean-Charles.
Good to see you, sir.
Bye, everybody. Goodbye.
Thank you.
Tomorrow is very important. Okay. Thank you,
Bye
Salman.
to everybody.
Thanks, Doug.
See you, Doug.
Thank you, everyone. Thank
Thanks,
you.
everyone.
Okay. Thank you. Bye-bye.
Bye.